Welcome to everybody that's joining our session today. Thank you so much for being here. We hope that you enjoyed this morning, afternoon's keynote presentations. So you've joined the Hacking the U.S. Healthcare System session with some wonderful speakers who will introduce themselves shortly. I am your tech support person. My name is Vanessa Brandsburg, and so I will be here basically to answer any questions that come up for you throughout the session regarding any issues that you may confront tech-wise. So please send a chat to me directly if you need anything at all, and I will go ahead and try to help you. Additionally, you can go ahead and direct any questions that you may have throughout the session to our moderator. And so the moderator is going to be collecting your questions so that they can refer them over to our facilitators and panelists so that they can get them answered during the Q&A section towards the end. You are muted, just as a reminder, and if you can also keep your videos off, that would be great, so then we can focus our attention on the presenters that we have. A couple other reminders is to communicate with fellow conference participants through our Slack channel, which has been really active and great so far. And then lastly, if you do have any other sort of conference-related questions, you can feel free to use our hotlines, both in Spanish and in English. The phone numbers for the hotlines are on our conference.coop website. So without further ado, I will pass it on to our facilitator to get us started today. Thank you so much.
Hi, everyone. Thank you and welcome to Hacking the U.S. Healthcare System. Thanks for attending, and we will get started shortly. Okay, like I said, thank you. We are excited that you joined us to discuss the healthcare system and, of course, the ways that we can hack it so that it can work for us now. We are fully aware that it's broken due to the numerous facts that healthcare is normally tied to employment or the cost of it being prohibitive for people even when they're employed. So we have our wonderful guests and panelists who are here to talk about the ways that they have been able to hack the healthcare system so that it works for them. And I'm going to introduce them briefly. And like Vanessa said, if you had any questions, please direct those to our moderator, and there will be an opportunity during this session for you to get those questions answered by our panelists. So we have today Kevin Bayuk from the Lyft Economy. We also have, and he is a leading researcher in the integrative healthcare. Oh, sorry, wrong person. His roots are in entrepreneurship, and he spent nearly a decade starting and growing technology companies and activating projects and organizations that regenerate healthy ecosystems and socially just and joyful environments. We also have John Blaska, who's the president and founder of Everspring Health. He is a leading researcher in integrative healthcare with a vision for creating a modern and economically viable globally accessible primary care. As a president and founder of Everspring Health, he works with team members in the development and operation of healthcare cooperatives. Then we have our very own Maddie Taterker, who's the membership coordinator at USFWC. She handles all of our members' benefits, including health, dental, and vision. And she'll be talking about some of the programs that we've implemented in order to make sure that our members and for other worker owners have access to the healthcare they need. And last but not least, we have Molly Hemstreet. Molly Hemstreet is the founder of Opportunity Threads. In addition, she is the executive co-director of the Industrial Commons. She founded that organization in 2015 to support industrial workers across her region. She's a native of Morgantown, North Carolina, where she continues to work and raise her family. So thank you, and we will get started with Kevin.
Thank you, Jaka. And thanks everybody for attending this session. I wanted to say a little bit about Lift Economy. As a worker-owned cooperative, one of our intentions is to help create an economy that works for the benefit of all, life without compromise. And specifically over the last 2 years, we've looked at some of what we call the traps of capitalism, the personal security strategies that make the transformation of the economy more difficult. And one of those traps, for example, is retirement funding, retirement savings, and we've started a project with certain partners like the Sustainable Economies Law Center called the Next Egg. And health was the next topic we were looking at. So we called the vision that we've been doing around that Next Health. And I think probably like all of us, the vision that we want to see in a health system would be universally accessible, and making sure that the emphasis is on preventative care and well-being rather than just death care or disease care. And also whole person, integrative, complementary, and alternative therapies and treatments that look at us as humans and authentically meet our needs for well-being. Of course, the problems are probably you're really well aware of. We have a for-profit insurance system and a complicated set of federal and state regulations. The care model that most of us are familiar with is really focused on disease treatment, not about prevention, not focused on diet and activity and wellness and the various complementary and culturally appropriate treatments and therapies that would contribute to well-being. And of course, there's disproportionate costs on birth care and death care. And of course, the pharmaceutical access and costs are heavily distorted by market capitalism. And so, and that all rests on, of course, on the backdrop of other problems of a massive amount of trauma, intergenerational trauma, structural racism, colonialism, and just the heinous cruelty of capitalism and how it shows up in the treatment of health. Okay, with all that said, we probably, like many of us, are advocates for Medicare for all. In our investigation of trying how do we reform or hack this system, almost all roads lead back to a strong advocacy for a state system like so many other nation states in the world have, of making a universally accessible single payer type of program. And we are, that is a policy platform that Lyft is a big advocate for, and we will see you in the streets in November to continue to demand and advocate for that. In the meantime, we have a guiding question: is there a way, using cooperative values, what can we do around the health system to provide some type of standard of care that's in alignment or as close to alignment with the vision for Next Health as possible? Next slide, please. And I wish I could say that I have the answers. We've totally hacked it, and the answer is we haven't, and we're still deep in discovery. And I wish I had more confidence in in different approaches, but I want to share what ground we've covered. So we looked pretty closely at the quote unquote alternatives to insurance. And to be clear, what's listed as alternatives here, the first two bullet points are not insurance, but in the benefit societies and communitarian organizations have historically provided something like insurance. And when the ACA, the Affordable Care Act, was developed, there was a carve out under the federal mandates for health share ministries. And so there's a number of those that have been around for a while. Christian Healthcare Ministries listed here as one of the larger ones. Freedom Health Share is another one. And if you're not familiar with these, basically the idea is these are not insurance, but it is a communal pool that's a non-guaranteed payment, and it's subject to a different set of regulations than insurance providers. In fact, it's a different agreement at its core. Since health share ministries were carved out, there's been the emergence of a couple of other medical cost sharing networks. that are secular in nature and not necessarily Christian, or there is one Jewish one, which I've listed there, United Refuah Health Share. But Sedera and Zion Health are two ostensibly secular medical cost sharing networks. Again, these are not insurance. There's some problems with them. As a hack, they don't fully solve all the problems. One is their relationship to pre-existing conditions. They're not under the same regulations that the ACA created with regards to insurance for pre-existing conditions. There may be coverage that is graduated, but if you are somebody or one of your employees, worker owners, has a pre-existing conditions, it's very likely that these would not be a fit or solve the problems, and still insurance would be required in some way. Whereas the federal mandate, the current federal administration eliminated the federal mandate to have an insurance coverage of a certain form. There are certain states that have kind of copycat the federal. California, where I live, is one of those. And these, the secular Sedera and Zion do not qualify for the mandate kind of piece. They don't check that box. And extraordinary costs, palliative care, other are treated, because it's not a guaranteed payment like insurance, there's some amount of risk. And each of these networks or cost sharing platforms tries to address the idea of extraordinary costs, but it's not the same, not nearly the same as as we might anticipate from a Medicare for all. So there's still some risk in the system. We've also explored mutual health organizations, so-called MHOs, specifically Paul Glover in the development of the Ithaca Health Alliance. He's written a great book, which is available at healthdemocracy.org, exploring different structures that are essentially communitarian or cooperative in nature and pooling of funds, very similar to a cost-sharing network. And his book provides some instructions of how to grow one in your own community, which we think is instructive, but still doesn't address the same challenges of pre-existing condition state mandates and extraordinary costs. What we've been exploring, our current edge right now, is what are the potential regulations for a number of cooperatives, even if they were small organizations and enterprises, to pool together to self-insure as a group. And so far, our learning has led to a couple of regulatory barriers, and we're seeking additional guidance from people who are aware of what those barriers are and what might need to be done to overcome them. And so the insurance alternatives is one piece, the care model is the other, and I think one of our additional speakers will speak about one of the logos there, the Everspring Health. There are some direct primary care models that are out there currently. When insurance is required, even if it's a high deductible insurance model, a direct primary care model might be perceived as a double cost, and this creates a lot of stress when care is already inaccessible to so many people. And direct primary care models are emerging that match up better to the Next Health vision for integrative, complementary, and whole person preventative wellness type approaches to providing care. I list a little bit of regulation. There's a House of Representatives bill that was introduced in, I think, fall of 2019 that maybe one of our other speakers might know even more about, that essentially would potentially have the IRS take a look at how it regulates HSAs. The possibility of using pre-tax HSA funding from employers, say co-ops like us all here, to actually fund employees to actually allow employees to use HSA funds for direct primary care models is something that we're tracking and are very interested in. And of course, I have another logo here, which is the PPC, this patient physician cooperatives, which is a type of direct primary care model, but it's explicitly a cooperative where the care providers and the customers, if you will, those seeking care, are in a cooperative arrangement together where costs and other aspects of the program can be determined in a communitarian way. The other things we're looking at and tracking, and I'll try and keep this short because I know we have a lot of amazing speakers here, is we're looking at, well, there already exists, and there may exist in your community already. We don't have, and we don't know of, a comprehensive directory of where these exist, but a number of midwifery groups have voluntarily formed cooperatives, as well as community birth centers, as well as cooperative and community-run and/or nonprofit hospice centers. There is a network of nonprofit and free clinics that are providing direct care, walk-in clinics and other clinics that we have a list growing, but we don't know, and maybe you all know, of a comprehensive directory. We'd love to be informed if there is one. And the final thing I wanted to share is in all of these things, the pharmaceutical industry and the way medicines are provided is in need of incredible reform. Even if there were a Medicare for all, there's still additional transformation of the system that would be required there. And we're very inspired by some of the recent work published by the Next Systems Project, looking at the idea of what would a nonprofit pharmaceutical company look like. What if we could collaboratively fund and grow a way where generic pharmaceuticals could be provided from a supported nonprofit pharmaceutical company to provide those types of medicines at cost, and what will we need to do regulatorily and from advocacy and just even a direct support platform to have that emerge. So again, I so wish I had answers and confidence around a lot of this. I hope sharing our learnings and any questions you might have can move you further along your journey of discovery. And maybe our other speakers have. I'm hoping for more insights. I'm ready to learn. And I welcome any questions you might have. Thank you, Ajaka.
Thank you, Kevin. That was awesome. And thank you so much for laying out the landscape of what we have and some alternatives and what it means. For the people who are just joining us, you're in Hacking the US Healthcare System. Please, if you have any questions, jot them down in the chat and we will send them to the moderator and we will get to them at the end of this portion of the session. Now, John is going to speak about Everspring Health.
Thanks, Ajaka. So as Kevin was kind of suggesting there, this is a big challenge for sure. And so the question for me this started about 20 years ago. And the question was, the healthcare is broken, like, why don't we fix it? And so the question I asked myself is, what would that mean? What is healthcare? Where does it exist? And so I traveled the world to observe how people practice healthcare, and then I looked for opportunities to put it in play. And so the chunk that we took off was to say, oh, if we were going to build it ideally, what would that ideal model be? And it would be a model of healthcare that meets the needs in the clinic, but also a business model that meets the needs from an affordable, accessible space. And it's no easy task whatsoever. So we had to kind of break it down into bite-sized chunks. And so we had to look for opportunities to execute the business model, which Kevin kind of alluded to, where there's so much interconnected components that kind of derail an overhaul of the whole system. And really the biggest area for opportunity is in primary care. So the challenge of it is like, so if we look back in 1978, for people that really want a good document to go by, the Declaration of Alma Ata was written in 1978 by the WHO, and it has great definitions for us to use, and it gives us a focus of what to do. And so if we look at the components that we kind of came up with, we had to, we felt that awareness was probably the biggest thing. What are the actual needs? And most people think the need is healthcare. And the truth is, the need is to improve the quality of life of human beings. And so when we think of it as delivering healthcare, we're actually thinking of delivering a system and resources. And that's a different space than trying to actually meet a need of an individual or a community as a whole. In the last 25 years or so, chronic disease has become the #1 medical need worldwide. And in turn, the primary care is the place to meet that need. We're used to the acute care model, which has been kind of mastered over the last century. But that's not the same as what we need for chronic disease, and it's not translatable. It has its place, and it's good where it is, and we don't need to kind of violate that to find a solution. So our goal is to look for lifestyle-related diseases. And so we want to make sure that the resources we have are available, and we have a misconception that we have to invent our way out to address disease, that we have diseases right now that we don't have answers to. And the thought is like eventually we're going to have to invent a device or a drug to get out of this. And the truth is we have to help people live a better lifestyle. And so when we get into the structure, I kind of mentioned about how we built an acute care model. We developed and refined that, and our job now is to figure out how do we meet people where they're at, how do we move healthcare closer where people live and work. And part of that is understanding the endpoints. The clinical endpoints for primary care must be rooted in the need that has to be met, and quality of life is that need. We have to look at the challenge, the benefit and the good and bad of quality of life is that it's both a subjective experience, and so that can be hard to get metrics to, but it actually can be an objective measure as well, and we can actually advocate for people to have better quality of life based on the statistics we have, and we can make offerings in that space. So, and that kind of leads us into health literacy. And health literacy is really understanding what health is, and for a person to understand what health is, how to recognize elements in their life where they say, I need to go visit someone and get something attended to. If we're going to change the way we offer care, we have to help people understand that primary care has to be different. It's not a place you go when things are finally broken, which is what our urgent care and emergency rooms have kind of become. Our job is to say, what do I need to do to keep my health going? What do I need to do to refine my experience? For us, our model is our end point to hopefully is going to get to be the point we want healthcare to be as accessible as a coffee shop. Why does someone go to the coffee shop? They might go read the newspaper. They might go have a cup of tea. They might have a cup of coffee. We want healthcare to be as accessible as we want it to be a weekly or a couple times a month at least. And so there's massage, there's acupuncture, there's chiropractic, there's a lot of any therapy really. So the modern primary care model will be more of a therapy-based model, and we need to help people understand what that is. And so we need to help people understand what health is, what healthcare is. Health is a measure of a person's quality of life. Healthcare is the facilitation of that quality of life. And then when we ask where does it exist, because health only exists on the level of the individual, healthcare can only ultimately exist between the patient and practitioner. And so that's the target we have to meet to be able to truly hack the system as we know it. Commitment. The commitment, it's tough. I mean, I've been doing this for a long time, and there's a lot of things that get in the way. But if we can focus on patient care, which is some of the things I think we do best, it's amazing what we can do for people. And so when our mission is quality of life, we always have a talking point. We always have a way of going into to have a conversation with someone to say, rather than, what's wrong today, is like, how are things today? And that changes the context, that changes the way we approach the situation. We can eliminate a lot of the bias that ends up being in play when we're trying to say, well, why are you here if nothing's wrong? Why are you coming to see me? Or if my job is to delineate which chief complaint is more important than the other, rather than saying, hey, the whole quality of life metric is important, we can get into trouble real quick. So quality of life has to be a commitment from the get-go. Mission-driven care is important. I think it's important because we have a lot of times where we write a mission statement and it hangs on the wall someplace, or we say it in a motivational space. but we don't actually go to work and try to fulfill the mission. In healthcare, I would say it's mandatory that it has to be mission driven. So the commitment for us, for Everspring Health, our mission is quality of life. So we can live out it every single day. Our name is that way too, Everspring. Every day we got to get up and we got to do it again. So our commitment has to be to that it's scientifically sound. We have to have repeatable results. We have to have reliable results. This is important, one, because we're taking care of people's lives and trying to keep them safe. But we're also trying to improve their lives, and we're trying to do it reliably, and we're trying to do it with accessibility, which means it has to be reasonably affordable as well. So if everything is available, things get expensive just because of a maintenance of that availability. We have to figure out what's the right way to apply resources and strategies. There has to be algorithms for care. There has to be models of care that run so that there's an efficiency there. But at the same time, it has to be paired with being socially acceptable. And to me, this is the epitome where a cooperative can plug into it. And so we have groups that live in different parts of the country. We have different ethnic cultures and personal experiences that need to be validated, and so the social acceptability is where diversity comes in, where we build in the ability to be dynamic to the needs of the individual, dynamic to the needs of the community, dynamic to the needs of the greater community. And so that's a key component to building a proper model. And the last part, the big hurdle, is trust. From a system standpoint, our biggest hurdle from our clinic is investment, is being able to scale our model. People don't trust in something that's almost opposite of what the standard is. Even if a person is ready to say, I don't like the system as it is, it doesn't mean that they're really ready to push that boundary. And so building enough trust so people can have faith in the system to actually invest and hold to it is certainly a big barrier for us as a whole. Practitioner trust. The practitioners, what I call clinical confidence, is probably a big thing from a practitioner standpoint. When we're recruiting practitioners, because again, we're thinking differently, you have practitioners who are concerned about patients. They don't want to do wrong. And so when they're trying to relearn something, some of it only comes when you've seen a patient go through the process and recover, and then you trust that what you did the right thing. And that's a big hurdle. And so when we talk about prevention, which is, it's kind of a generic term, your prevention is really removing the burden off a person, right? We have inflammatory burden, we have pathogenic burden, which are the two big categories of burden as we age. And so you're actually going in from a prevention standpoint, you're going through and trying to remove the different burdens. And a practitioner has to be able to learn how to have faith in that process and see the results, and then it kind of doubles down. And then the last place for sure is building patient trust. We need patients to buy in, and I think this is where the cooperative model works really well, is that the cooperative model, we can ask when people come to our clinic and they want to become a member, in our document, we ask them, you're committing to being responsible for your health. And that our job here is to partner together to solve this, this endeavor. And so creating patient trust is a 3-month, 6-month, 12-month process, depending on the condition a person's experiencing. And so being able to build all that kind of component, and it just kind of cycles back and forth, and trust leads back to awareness. If a person has awareness, they have trust. And so the cycles, it just kind of keeps going each day, and we just have to renew that commitment as we go. But I'd like to say confidently that it can be done. I'll be honest, I can't do it personally. It's got to be bigger than me now. And I'm certainly looking to have people help me with that. So I would love to connect with people who are interested in doing so. Thank you very much.
Thank you for that, John. And thank you for outlining basically the building blocks of what the healthcare system is and what we need it to be through that really great graphic of awareness, trust, health literacy, and commitment. Now we're going to hear from Maddie, who's going to talk about member benefits at the U.S. Federation and how she's navigating the health system in order to get benefits to our members.
Great. Thanks so much, Ajaka, and thanks to John and Kevin for giving that really big sort of overview of the system that we're working with and what some of the major challenges are to accessing healthcare in an accessible way, in a way that doesn't break our banks. And I'm gonna talk a little bit more specifically about the work that we're doing here at the U.S. Federation of Worker Cooperatives to try and bridge some of the gaps for our members in accessing healthcare and different types of insurance. Because one of the things that we're up against in this country is that healthcare and access to health insurance is so often directly tied to employment and or a sort of traditional nuclear family structure. You access benefits either through your workplace or through your partner or parents otherwise. So here at the U.S. Federation of Worker Cooperatives, we have our worker benefits program so that workplaces who are part of our membership can more easily opt in to different group health benefits. So very much working within that system of benefits being offered through the workplace, but acknowledging that that people need care right now. So for the past several years, we've offered a national dental insurance plan and a national vision insurance plan that is available to almost all of our member workplaces. And here on the right, you can see that we have about 40 of our members enrolled in dental or vision insurance on this national plan, which means that we have about 500 people enrolled on these national plans. And basically what this means is that with insurance, as you scale up the number of people involved, costs go down and quality of benefits increases, because there's a larger pool for the insurance company to sort of manage. So what that means is that instead of these 40 member workplaces having small groups and paying high prices for small groups of, say, 2 to 50 people, we have a 500-person group that has consistent low rates across the entire country. So those are our sort of keystone programs that we have right now. And this year we'll be rolling out sort of similarly available accident and disability insurance. We also have some options for tax advantage reimbursement plans, which is sort of a blanket term for health reimbursement accounts, health savings accounts, and flexible spending accounts, which are very much tailored workplace to workplace. And we also offer some group health insurance rates through our broker partners, Diversified Human Solutions. And we've been able to find advantageous group rates in some states across the country, though I'll talk in a little bit about how complex the actual medical insurance marketplace is. That's created some real barriers for us in that avenue, and that is a large part in what Kevin and John were speaking to. And I also, of course, need to plug that open enrollment for 2021 dental and vision and accident and disability insurance are starting up on October 1st. So if you are a member of the Federation or you'd like your workplace to become a member of the Federation, you can most likely enroll in those benefits, and please contact me or go to our website, usworker.coop/worker benefits for more information there. I also want to briefly touch on some of the amazing work that Ajaka is doing with Gilded, which you all got to hear so much about during our keynote. That was really amazing, just framing for the work that Ajaka has been doing. We both are pretty new into this work, but have both been sort of rolling along together. So Ajaka has built some relationships for the Freelancers Cooperative in that DMV, DC, Maryland, Virginia area with a direct primary care, 1 or 2 direct primary care clinics, so that members of Gilded in that area can more easily access those direct primary care clinics at a group rate. And of course, part of the function of Gilded is to provide a steady origin of income, and essentially creates a portable benefits model so that people don't have to rely on the workplace being like each individual gig for benefits, but can have benefits through Gilded that they take with them as they move through different freelance type work projects. And that ultimately does serve to then detach those benefits from the workplace, which, like I said, and as John and Kevin have spoken to, is such a sort of key barrier to accessing quality healthcare in this country, especially as we move towards a more gig economy focused type of economy, and as unemployment rates skyrocket during the pandemic. You know, it's absurd that we live in a country where we are experiencing a pandemic, and while people are losing their jobs based on this economic crisis, they're also losing their health care. So obviously we're looking for creative ways to move past that. Ajaka, can you move to the next slide, please? So, like I said, with the programs that we've been able to create, the dental and vision programs in particular, which we've been growing over the past several years, one of the big strengths is that we get these advantageous rates and higher quality benefits for less money, which means that people across our membership are able to access dental and vision insurance and get that really critical dental care and eye care needs that are both so central to overall health, but so many people lack that coverage because it isn't included in general medical benefits. By centralizing our benefits through the Federation, we're also able to centralize research and administration. As the worker benefits coordinator at the Federation, I both support all of our participating members with their administration, helping alert people to deadlines, make sure that folks are filing the correct paperwork and have all the information that they need, while also doing research to expand these programs, make them more efficient, make them more inclusive, make them deeper, and I'll get into some of the places that I've been researching in this role later on. And then we have our challenges, which is that the US healthcare system is extremely localized state by state. So for medical insurance, the insurance that you'd use when you need to go to the hospital, when you have a baby, when you are dealing with end of life care, or any other sort of primary care need, all of those markets are state by state. So it's really, whereas we have the national dental and vision networks, we really can't offer that for a national healthcare program at all, which is one of the reasons why, you know, I and also the Federation as a whole, you know, our policy goal is also Medicare for all, so that we don't have to be trying to work out the pieces of how we tie healthcare into a worker cooperative. Also, like Kevin discussed at length, with a lot of these different types of workarounds in terms of the cost sharing networks and the direct primary care, focusing on primary rather than acute care, there's a lot of exclusion of people who have more complex healthcare needs. And of course, even when we are able to offer lower group rates for certain states' healthcare programs, the costs are still too high. You know, I talk to members very often who are searching and trying to find healthcare for workers that is, you know, not $300, $400, $500 a month for basic insurance plans. And they really, I mean, unless you're able to qualify for Medicaid, which not everybody is, those plans really don't exist. So if we're talking affordable means $300, $400 a month, like what are we really saying here? You know, that's still prohibitive. That's still, we're not bringing that kind of money. And yeah, and like I said, the alternative models have shortcomings as well, and are going to leave gaps where general insurance doesn't. So yeah, in order to try and push forward and continue to be creative, we're having discussions like this one where we're talking about the different types of healthcare models and what we are hoping for, what we need, what we're lacking in the US healthcare system. One of the things that we're looking at is the creation of some sort of benefit association, which would allow either worker co-ops or their members to join in order to create a sort of portable benefit system within the worker cooperative community, so that workers could have benefits that are tied to their sort of affinity for the worker cooperative movement and association with it, but not necessarily a specific workplace. Going into those portable benefits across the co-op sector. And then we are looking at different ways of exploring those direct primary care and medical cost sharing avenues in ways that are effective and useful for our members without leaving the people who need it most behind. And yeah, I mean, I'm really looking forward to hearing from Molly next, who is joining us from one of our members who's part of the dental and vision program, and I know has done a lot more in addition to that to access or to address healthcare needs. So take it away.
Thank you so much, Maddie. That was great. Thanks for just reiterating in a way just how much power there is in strength, how much strength there is and power there is in numbers. And like you said, yeah, we're going to go to Molly, who's going to give us on the ground view of what it looks like to have a cooperative and need to get health insurance. So feel free to jump in, Molly.
Okay, great. Just being sure you can hear me okay. And if you wanted to go ahead, thank you, Ajaka. Thank you, Maddie. Thank you all so much for this conversation and just for the incredible organizing that the U.S. Federation and DAWI have done to bring us these conversations during this time in a really thoughtful and organized format. So I really, really appreciate that. So again, my name is Molly Hemstreet. I'm in Western North Carolina. I'm the founder of Opportunity Threads and also the co-director of the Industrial Commons, which is really putting together an ecosystem in this industrial rural area where we are in North Carolina. And we have 5 startup cooperatives that we're working on, and all of us are enrolled through the Federation in dental health, and we've been very lucky to also be one of those states that we've been working with diversified human solutions with healthcare as well. So I will talk a little bit about that, but I also want to just kind of give a snapshot on just really coming at this from a pandemic perspective and how we're just trying to survive in our community and what we've been able to leverage and push in terms of making sure that in this moment right now, in a really critical time, the members of our cooperative are safe and protected because many of them we are making personal protective equipment, PPE. So we need to be healthy so that we can also try to keep other people healthy as well. So I want to go back and think kind of about the pandemic has hit our cooperative really, really hard. As many of you all know, our cooperative is made up primarily of Mayan, Indigenous, Guatemalan folks. And so this community has been hit really hard. We've had the death of 4 family members of cooperatives. So it's something we felt very, 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 very viscerally and very emotionally in terms of being part of the pandemic. And then we are also part of another large employer in our community is a meat processing plant. So when we felt like we were kind of canaries in the coal mine back in March. There was an outbreak at our cooperative. So we had to really get our ducks in a row quickly to understand what we were going to do and how we were going to keep people safe. So one thing we did is we organized, and we were actually the first business in our entire community to say we had to be proactively tested. So we actually organized to really push the leadership in our community to force our meat processing company to be tested, all 800 workers that were there, because we thought that that's where a lot of the symptoms and the cases were coming from. And then we were the first company in our community to test all of our workers. And you can see here, poor Walter is waiting to get the dreaded nose swab, but it was our cooperative organizing and going into our healthcare system and saying, look, you have to come out and test our workers, because we had fears that we had folks that were sick, and that is one thing that they did. And then that we became a model for other people to say, hey, we need to proactively test the other workers in other facilities. So I just wanted to kind of give that as a little bit of a background of some of those things that really helped us open our eyes to how important it was that we had the benefits and the health benefits that, for example, from the U.S. Federation, having access to health through the diversified human solutions and also vision and dental. This also brought up a really interesting time for us. We developed a very strong relationship with our hospital. You can see them outside our plant here, testing all of our workers in our ecosystem, not just in our cooperative. We tested all the cooperatives in our ecosystem, about 75 workers at this time. And then what we really developed out of this was this healthcare membership at urgent care. So we are in an industrial area, and a lot of folks have on-site nurses, and a lot of industrial manufacturing plants have on-site nurses, but you need to be like, a plant of usually a couple hundred to be able to sustain an on-site nurse. So what they have developed, and we've really helped kind of push this, is an off-site nurse at an urgent care center. So it's a combination of this urgent care center is part acute care, part primary care. And so what we're working with now is to develop, it's not health insurance, because some of our folks have opted not to have health insurance, even though we're paying either 50 to 80% dependent upon their ownership status within the cooperative. And some folks are saying like, yeah, still, we don't necessarily want to take that. So we're understanding of that. But instead of just having nothing, what we're doing right now is developing this membership at the urgent care clinic, where for general healthcare needs, folks can go in, show their membership card, and be seen at any hours of the day. They're paying $7 a week out of their paycheck, and the cooperative's paying $15 a week, so that they can have this membership at any time of the day. And then the other thing that allows us to do is more proactively go after COVID testing. So we have negotiated with our main client to be actually proactively pay for our own COVID testing. And this is just so important for us. We're in a building together. There are 52 workers. We've actually broken it into 2 shifts, but and I think that's really important for cooperatives thinking about how are we gonna manage ongoing COVID testing, is we are, again, working with our clients to pay for us to keep our workforce healthy. And I think that's really something important that we think about, is not just the healthcare system, but how are people that are interacting with the healthcare system holding our clients accountable that are using the benefits of the labor of our cooperative. So one nice thing about all of us being at the same urgent care clinic is that we can get those test results back quickly. The workers and within our cooperative give the cooperative permission to get their test results, so that we can very, very quickly almost create our own method for tracking. So we'll be taking all those now as the 15-minute rapid test, so that we can very quickly assess where people are. So there's one nice thing about all of us going into the same clinic and using this membership card, whether you have insurance or whether you just have this membership card. I think that's very, very important. And so I just want to emphasize what we've tried to do and encourage other people to think about this group testing, the ongoing COVID testing, and trying to keep, particularly, in our case, communities of color would have been grossly impacted in terms of this. And a lot of the deaths in our community are coming from the immigrant community. And then I would just want to say, like, some of the other things that we're trying to do with creative time during this is there's this huge, I think, mental weight of our students and our children. Mine sitting over here, he finished out of his work and he's sitting beside me, and it's so hard for working class people. I mean, we're in industry. So one, I think creative benefit we've used, which is for our mental health, is our cooperative has hired a teacher. And then this allows workers, while they know during the day, if their child is trying to be on Zoom or whatever it is, they have a certified teacher that's going in. So we're really seeing that help mitigate not only the physical health, but the mental health of what's happening to our families at the same time. So we felt like that's been a creative benefit that we've been able to develop during this time. So I know it's not necessarily directly related to healthcare, but I think it has been an interesting way that we've been able to mitigate a lot of the stress right now here in this moment of what it means to be living and trying to actively and safely work in the pandemic. And then I would just say, and then the other side of the work of our cooperative is then participating in the production of masks and gowns. We have been part of our industry network, the cooperative, the Carolina Textile District, have now produced over 500,000 units that are going into state stockpiles and masks and into the cooperative movement. So it's really important that we're thinking about this moment of healthcare and how we can all participate. But kudos to the Federation for allowing us to have those benefits. I know we've been kind of guinea pigs for that, and we've just are so appreciative of it.
Thank you so much. That was absolutely beautiful, especially to hear about all of the ways you guys have creatively decided to provide benefits, even if it's not the traditional health insurance. So I'm going to bring back all of the panelists, if you could. Yeah, thank you. We're going to open up to questions. I know people have been putting some questions in the chat, so I have a Google Doc from which I'll be addressing the questions to our panelists to answer. And please feel free to continue to ask questions. We'll have about 10 to 15 minutes for this section. So to get started, there is one question who asks, how do we balance these relatively small scale interventions, direct primary care, dental vision insurance, clinic access, with the extremely real need for a massive system overhaul? And you can jump in, it's popcorn.
It's a very provocative question. And, I could see it relating to a number of spheres of transformation that are needed. Certainly, healthcare is urgent, timely, and critical to human well-being, and so it's a big one. But I think there's other areas where there is incrementalist, small-scale stuff that I think is really important and urgent when both and simultaneously an overhaul, a complete transformation is also required. So I think different frames and ways to share when we do our advocacy work and just work in general, we try and frame everything as a both and. Yes to small scale interventions when they're timely and urgent, and at the very same breath saying yes to Medicare for all or yes to the big intervention and the policy initiative, and to try our best not to separate those things such that we don't get stuck in a design cul-de-sac of like the small scale interventions, which oftentimes are inadequate for the overall need. We just don't want to get stuck there. So it's okay to be enthusiastic about the small scale stuff because there's important things there, but in the same breath, the same frame, however, just to name both. That's the best I can say is we just name both.
And I think there's a distinct challenge with the breadth, the size of the system. When some people are saying we need to, hack the whole system, you have to build the new model to make the existing model obsolete. And there's a lot of components that can be done there. I think some of it we have to kind of go through and write down the parts that we can accept, that are actually performing reasonably well. Maybe there are cost issues there and stuff like that, but the actual performance is surviving and is actually somewhat sustainable. I think we have an issue with abandoning individuals. So I think we need to get people, we need to get care closer to where people live and work. I think that's kind of the biggest and most targeted space for us to begin and to rebuild. And inevitably that will bring costs down, and then you'll have some data. So when people are talking about Medicare for all and that type of stuff, there'll be, the data they're using to calculate the cost of Medicare for all comes from the system we have, and that makes it very difficult to implement as well. And so we need some of the data to show people that we can do this affordably. And I think that's one of the elements we need to do to address this.
And so I'm glad that like the systems guys weighed in first. I think there's also just something about, I was amazed in my interaction with the hospital, even though they are part of a system and part of this very even bigger system of Carolina's medical system, how willing they were when we presented a logical model of how we could help, that they were like, yes, we want to try to help you. So I think, trying to find the ways we can break into the system when we can bring thoughtful models of helping to relieve suffering that are really proactive. I was amazed how responsive they were to us. So, I think if we can think about, yes, over here, we're going to try to build out and support what the Federation is doing wholeheartedly, get as many people into that. We're also going to try to break in and make the system that currently is there for us more supportive of the workers we have, while we're also trying to advocate for the bigger all systemic changes as well. So I would just, encourage you not to underestimate your power to think about really strong, thoughtful local models that can be influential in shifting your systems that are already part of these larger healthcare systems that you're already having to interface with. And I would just think about that.
Yeah, I mean, this is a huge question. I think that something that, in my position, I am not an insurance professional, but also my job is to like administer insurance. And a lot of that, I mean, I'm just always trying to keep the humanity of the people that I am working with at the center of everything that I do, because I think that this system is so stacked up to be like, well, you don't get access to this kind of thing. And I think that, like, I don't know, there's something really deep in that about needing to like not lose sight of these really small scale things that we're doing in the midst of the need for massive overhaul. And like we have to understand also the system that's saying why, like, no, this one thing isn't available, in order to make our way towards what do we need to do to unpack that system and completely transform it.
Yeah. Thank you for that. Yeah, those are all really good points, just pushing forward that there really is a need to continue with what we can do in the moment and not just abandon it to what we should be doing and not take the steps we need to get the people the health care that they deserve. So there's some specific questions from to some of our panelists. So for Kevin, there's someone asked, I heard about a cooperative hospital in Germany. It's maybe to everyone too. Does anyone know about anything about it, and could it work here in the US? It's a bit vague, but if that rings any bells.
In our research, we did a little bit of searching for models outside of the US, but maybe not as much as John or others who have kind of looked at the world and how other people are handling it. And we did find at least one noted worker-owned cooperative or majority worker-controlled hospital in Germany, Spremberg or something like, I forget exactly where it was. And it was interesting. And I don't know that there's any reason why a clinic or scaled up to a hospital with what a hospital might provide could not be worker-owned, worker-controlled. worker governed. And so could such a model exist in the US? There are nonprofit clinics that operate in a communitarian nature as like self-directed nonprofit clinics that already exist in this country. And there may be co-op clinics. Again, one of our asks is hopefully somebody out there knows of a directory or an index of the community clinics with some type of communitarian values. And we just don't know of such a comprehensive directory, that we have a list of like 20 or 30 examples.
Anyone else who might be able to speak to the other part of the question in terms of could such a model work in the States?
I'm not familiar with the German hospital, but we have group health in both Wisconsin and I believe Oregon and Washington. And I mean, I don't know how much they are cooperatives anymore. In Minnesota, we used to have group health as well, and they've become health partners. As an insurance person who buys insurance from health partners, you can go to their annual meeting and cast a vote. They've established the barrier between practitioners and owners, and so that's probably the biggest thing there. But as far as worker owned, I don't know of any reason why it couldn't be done. The worker-owned component of it actually removes a lot of barriers from the healthcare segment of it. The biggest challenge I see there, which is probably very few people are investing in healthcare models. So even the big providers aren't investing in models of care. In Minnesota, everyone's been buying and building hospitals and not doing much on primary care. We're starting to see a trend more towards primary care, moving things closer, but there hasn't been a lot of investment, and there's certainly not a lot of like venture capital type, or outside type of help. And that's probably one of the biggest challenges, I think, in the cooperative area, is actually getting a cooperative up and running is the hardest. This is my third different business, and building a cooperative was way harder than any other business model. And so that is a hurdle that I think, if we could, figure out a solution there, I think that might build some opportunities to get this thing going further.
Yeah, I also,
Go ahead.
I think that, I think there's a lot of really amazing work in the labor movement that's happening within hospitals and within healthcare settings. And I think, there's a major intersection there if we want to talk about worker ownership in healthcare from a clinician and clinical workers sort of standpoint, and the intersection of that with labor. There's really strong nurses unions in this country. There's really strong tech workers unions in this country. Medical residents are doing some pretty incredible organizing. Wanted to just name that in there, because I think that holds a really important place when we're talking about making a healthcare system that is more human and less driven by profit and white supremacy.
Thank you. The next questions I'm going to kind of aggregate so that we make sure we get through all of them. So this is for, one is a clarification. There is hope for, someone talked about the lens of cooperatives and pharmaceuticals. I think that was you, Kevin, and the combination of two. There was a clarification as to whether you were saying there was hope for that to happen in terms of its formation, or if it already exists. And I'm going to add one more question to that. For Molly, someone asked, I would love to hear the name of the urgent care clinic where Opportunity Threads has membership. And could you describe the amount you pay per month per membership and the services available?
Great. I'll share what we've learned about pharmaceutical organizations. We know of, so Next Systems, I'm forgetting the name of the writer and thinker there, published a document, I think it was called Medicine for All. I'll find the link. Dana Brown from the Democracy Collaborative, Medicine for All, and basically looking at a public owned option for pharmaceuticals. And that document, the report, Medicine for All, has some exploration of alternatives and is informed by communitarian principles. I'm not going to say there's a worker-owned cooperative or producer cooperative pharmaceutical company initiative, but a more public stakeholder or organization. And over the last few years, we have been tracking the emergence since 2018. I think 3 or maybe 4, and depending if you're counting 5 other organizations, have emerged as in this country as nonprofit pharmaceutical providers. Fair Access Medicines. There's a women's pharmaceutical company called Medicines 360. There's Civica Prescription, civicarx.org. And then there's one very specific to, I think, Narcan. It's called Harm Reduction Therapeutics. That was funded as a concession from Purdue Pharma for opioid addiction treatment, I believe, a pharmaceutical treatment for addiction. And then I suppose you could probably lump this in there. There is a new pharmaceutical company, public benefit corporation, that's wholly owned by a nonprofit in California called MAPS, that is looking at the medicalization of certain psychedelic pharmaceutical drugs. So those are the 5 that I know of. And again, our research is not comprehensive, so you might know of others.
Jack, would you like me to answer the?
Yes, please go
Okay,
ahead.
sure. So we are part of, for Western North Carolina, there are these kind of 2 big systems, and we're part of the Carolinas Medical Blue Ridge system. And so this is the Carolinas Medical off-site clinic. It's known as the clinic beside Walmart. So you go to the clinic beside Walmart. And they're the ones that help do all of our COVID testing. So this is all just happening right now. We're promoting this, and our contract with them will start October 1st. We sent all of our COVID testing through that anyway, so everybody's kind of on site already, but there'll be a contract. So we have to have a minimum of 15 people, although we're encouraging all 52 of our folks to take this on if they don't have, even if they do have health insurance, because this will allow us to streamline our COVID testing and be able to get responses back very quickly, because that's the name of the game. If that person they need to, go and quarantined. And so we're just taking that on ourselves. And so what we're able to do is we will have a contract with Carolinas Medical Offsite Blue Ridge. And we have to have a minimum of 15 people. It's $40 a month. They have different tiers. So we're doing kind of the tier that also includes some preventative, some health education on eating, diabetes, which is important for the community that we're part of. It does a well check. So there's kind of this simple primary care but that's also then you can just walk in at any time. You don't even have to have an appointment. So it's their off-site clinic, which is, again, in this manufacturing context, there are a lot of on-site clinics that they help run. This is for smaller manufacturers that can't hire a nurse. And our contract with them will start for October 1st. We have to maintain 15 people, and we can, similar, like you can't just go in and go out. You have to at least stay in for 3 months at a time. And I'm happy if anyone wants to email me, I can put my email out there, and I'd be happy to share this. If you wanted to go put pressure on your hospital or say, hey, look what they're doing over here. Can we add something similar? The people have been very, very helpful to us. And I'm sure they would probably share how they were able to set up this kind of hybrid urgent care, some very basic primary care to help people, particularly during this COVID time.
Thank you. So it doesn't seem like we're going to get to all of these questions. I have one more question that I think is general enough to ask, and we will work on how we can get you answers to some of these, because we have been saving them in a doc, whether that's putting it on a website. Go ahead, Maddie.
One thing also, I'm looking at the doc of questions as well, and I do want to plug that if people have specific questions about what their options are for their own worker co-op, if you email benefits@usworker.coop, you'll reach me, and I'll try and connect you with resources or answer questions as best I can.
Perfect. And we'll be sure to put that in the chat as well, so people have the email address. And Molly, if you want to send the moderator your email, and he'll share with the chat as well. We also have an email from John to share. So this last question I'll propose is, does anyone have any advice for tiny worker co-ops that are LLCs with small budgets to create healthcare support for its workers?
It's really, really hard. LLCs are a really hard framework to offer benefits because most of the regulations around benefits make it very hard for business owners to benefit the most from businesses, which is something designed to create, that's meant to protect workers. But in our context, when we're using LLC models as a worker ownership structure, it obviously backfires on the workers themselves. There are some scenarios in which LLC co-ops can access group healthcare plans. It also could be a prime type of group to form a relationship with a direct primary care provider if you're in an area that has them. And some LLCs can join our dental and vision plans. And also the accident and disability that we have available. So those are some options. I've been doing a lot of research on LLC troubleshooting because it's definitely not a one group problem. A lot of worker co-ops that mine included, that started as LLCs because it's a simple and accessible ownership structure. It's very hard down the line to create comprehensive healthcare benefits.
So I would just add, we're an LLC and all our cooperatives are LLT2s. And just so I think y'all have worked really, really well with us, Maddie. I mean, now they're probably, I think, yeah. So our numbers are getting up there. We do elect to be taxed as a corporation. So it allows there's different benefits and and drawbacks for that. But that's allowed us to really navigate this system well. And so in North Carolina, we don't have the most progressive cooperative law. So that's how we are navigating our structure and navigating the system as well. So happy to talk to anybody about that and give you the name of our cooperative lawyer. You need help with that as well. He's great.
I'm gonna hit you up to that lawyer.
Yeah, you
Thank
can hit me up. We got to find ways, going back to that initial question, which I think nailed it. How do you do this and just relieve suffering? And I think you said it really well, Maddie. How do you meet the humanity of all of this in a system that's broken? And I think we have to put our minds to it and work at both ends. But I think the systems we have, we can find creative ways to navigate it and not just provide benefits, but provide really quality and scalable things to the people that are, that are in our cooperatives.
Brad.
Thank you, thank you, thank you. And with that, we're gonna move on to our activity section of the session, and which is a mood board, which I will share now. And basically, since this is a hackathon, or hacking the healthcare system, we're gonna do it in a hackathon fashion. We wanna know, what are your dreams for the healthcare system? You can go to this link that's on the slide, www.kudoboard, kudoboard.com/boards, insert a whole bunch of letters, which will also be put in the chat so people can just copy and paste. Just pick a picture or a GIF or an image to share your dreams about healthcare. As we're hacking the system, what we want to keep in mind is, where are we going? What's our goal? So that we can know when we're there and know when we have a lot more work to do, and what efforts and initiatives we should be investing in order to get there. So we're gonna give you 10-ish minutes to fill out the board, and then we'll come back and have our presenters, our panelists comment.
Maybe 5.
5 minutes? Okay, give you 5 minutes. So we were initially hoping to have music, but we ran into slight technical difficulties. I'm gonna bring people back, and oh, yes, yay, Maddie fixed it. Okay. That's beautiful. So I'm gonna resume sharing, and hopefully you can see my screen where people have added their thoughts about what they envision the healthcare system to be. Someone put, as complex as necessary to address the variety of human healthcare needs, as simple as possible so that it can be done well and sustainably. How about helping people identify and meet their vital needs on a weekly basis to improve mental, emotional, and physical health? That was from Benjamin Bradley. Someone put a picture of people interlocking thumbs and hands. Sunshine picture. Health and healthcare is shared by everyone collectively as we are taught to care for ourselves and each other and access an equitable, affordable, just healthcare system that provides for dignified life transitions and appreciates the soul in everyone. So I'm gonna scroll through, and panelists, if there's anything that catches your eye, feel free to let me know and to stop and respond to it. Now, you can also go to the link that's pasted in the chat to see it yourself.
Something I love seeing here. Oh, now you've got to stop your sound sharing. Okay. Cool. Something that I really love is seeing the medical workers in Cuba and just being reminded that they're like our models around the world. Like we are our special United States little world where we're doing healthcare like this for some reason. We know the reasons. But there are so many models for places that have done healthcare in a way that is certainly not perfect, but is much more accessible, much more available, and it can be done. We're not asking for something that is outlandish or impossible. And I also want to shout out Rebecca's line that is anti-racist, all bodies are cared for, not fat phobic, and not classist. And the reminders that we've had throughout this that Medicare for all is an amazing policy goal and also is not going to be the single thing that fixes everything.
Anyone else would like to reflect back on what they're reading from the board?
I think I saw one that was referring to more weekly type of visits, and I think that's a good model from a primary care standpoint. There's a lot to dig in there, but making the primary care as accessible as possible should be thought of as like, how do we create an environment that's as simple as the coffee shop, right? Have people in the waiting room grab their tea in the waiting room and read the paper, and whether they have an appointment or not, they can come in and just socialize. They can see if there's classes available or other components, and so make it as seamless into their lifestyle as possible. And then that's where it can be customized to neighborhoods and needs of the cultural needs there. The primary care space, most people are not in emergency need. So there's a lot more flexibility to pause and breathe for the patient and the practitioner, so the practitioner doesn't have to feel worried or scared, and the patient can actually be validated and heard. There's a lot there, and I know it takes time and the experience to be able to kind of settle into it, and that's what I would encourage. And it's nice to see other people commenting that on the board.
Molly, any thoughts? I saw your son there.
Yeah, I was sharing my son the board. I was like, come look at these are great. Just the emphasis on mental health, I think is, not to make the assumption that that's included on this, but just explicitly say, I think that's been so important. I think we've been really looking at that in our organization at such a hard time, and how is the mental health just an assumed part of this conversation. So I want to lift that up as well.
Kevin, any thoughts you'd like to share? Any gifts that popped out to you?
My comments would be redundant to what's been shared, and inspired by what's here and listed, and I think it captures a lot of what I think is important and timely.
Thank you. So we're actually ahead of time. I will say that before we close, there will be evaluations that will be put in the chat. So we encourage you to please fill them out. We want to know what you thought about our panelists. And I also want to just say thank you so much to Kevin, Molly, Maddie, and John for sharing your knowledge and your perspective and just your experience of navigating the healthcare system. And again, in the chat, we've dropped some contact information. So if you'd like to reach out to some of our panelists, please contact them at the email addresses that we've given you. And I know we didn't get to all of the questions, though, and they seem like they were kind of more the meatier ones. So we'll be sure to share with the panelists so they have an opportunity to respond, and we'll get that out the best way that we know possible. I don't think there's much. I might put the host on the spot to let me know if there's more I should say. Host.
All right.